Good morning, and thank you for the opportunity to present today. My name is Equilla Cherry, and I am a Doctor of Nursing Practice candidate at Maryville University's Catherine McAuley School of Nursing. Today, I'll be presenting my scholarly quality improvement project, long-acting injectable antipsychotics as first-line treatment for the first episode of schizophrenia. This project examined whether implementing clinician education and a standardized treatment protocol could increase the use of long-acting injectable antipsychotics and reduce psychiatric readmissions among patients experiencing a first episode of schizophrenia or psychosis. I would like to express my sincere gratitude to my committee members for their guidance and support throughout this project. I am especially thankful to my committee chair, Dr. Jennifer Holtner, for her mentorship, expertise, and encouragement during the development and completion of this scholarly work. I also extend my appreciation to Dr. Joanne Kern for her guidance on the project's methodology and implementation, and to my community member, Dr. Malika Pritchett, for providing valuable clinical and organizational insight that ensured the project remained practical and relevant to psychiatric stabilization practice. Their collective support was instrumental in bringing this project from concept to completion. Thank you for your continued encouragement and dedication. I'll begin by discussing the background and significance of the project. Around 24 million people globally are affected by schizophrenia, which is commonly diagnosed during young adulthood, typically during an individual's most significant developmental stages. Poor adherence to oral antipsychotic medication continues to be one of the greatest challenges in psychiatric care, as poor adherence has been shown to be a direct contributor to illness relapse, hospital readmissions, and increasing healthcare costs. Over 50% of individuals with schizophrenia will discontinue taking their oral antipsychotics within 1 year, and rates of discontinuation are even higher during the first episode of psychosis, the time period in which treatment is the most beneficial. Long-acting injectables, or LAI antipsychotics, are one strategy used to address non-adherence by providing a consistent and continuous treatment that is administered at regular intervals, thus reducing daily pill taking, but are routinely underutilized by clinicians due to stigma, provider bias, and systemic barriers to early access as a first-line treatment. This project examined whether a standardized provider education and a standardized LAI protocol would lead to an increase in early access to LAIs, thus reducing readmissions to a psychiatric inpatient unit for those with a first episode of psychosis or schizophrenia presenting to a psychiatric crisis stabilization unit. The literature review identified four major themes that guided this quality improvement project: the impact of non-adherence to oral antipsychotics, the benefits of early initiation of long-acting injectable antipsychotics or LAIs, improvement in patient-centered outcomes associated with LAI use, and the persistent barriers limiting widespread implementation. Together, these themes highlighted the need for evidence-based strategies to promote earlier adoption of LAIs in individuals experiencing a first episode of schizophrenia or psychosis. The first theme focused on medication adherence. Non-adherence to oral antipsychotic medications remain one of the leading contributors to relapse, psychiatric hospitalizations, and poor long-term outcomes among individuals with first episode schizophrenia or psychosis. Studies consistently demonstrate that many patients discontinue oral medications within the first year of treatment, significantly increasing their risk of symptom recurrence and repeated hospitalization and functional decline. The second theme emphasized the importance of early initiation of long-acting injectable antipsychotics. A growing body of evidence supports introducing LAIs earlier in the course of treatment rather than reserving them for patients with multiple relapse or chronic illness. Research has shown that earlier use of LAIs improve medication adherence, reduce relapse rates, decrease psychiatric hospitalizations, and promote greater continuity of care compared with oral antipsychotics alone. The third theme highlighted improvements in patient-centered outcomes. Beyond reducing relapse and hospitalizations, studies have demonstrated that LAIs are associated with greater treatment satisfaction, improved quality of life, enhanced psychosocial functioning, and better opportunities for long-term recovery. These findings reinforce the value of focusing on outcomes that matters most to patients in addition to traditional clinical measures. The final theme addressed barriers to implementation. Despite strong evidence supporting LAIs, provider reluctance, stigma surrounding injectable medications, insurance authorization challenges, limited resources, and inconsistent organizational protocols continue to hinder their widespread use. These barriers underscore the need for clinician education and standardized workflows to support evidence-based practice. Collectively, these four themes provide the foundation for my quality improvement project by identifying both the evidence supporting early LAI use and the practice gaps that needed to be addressed through clinician education and implementation of a standardized EHR protocol. This project was designed and executed in accordance with Lewin's model of change, addressing the three established stages of unfreezing, changing, and refreezing. During the unfreezing phase, baseline chart audit data, along with the evidence generated in the published literature, were disseminated to clinicians, creating an awareness of the current practice gap and a desire to modify existing prescribing practice. The changing phase involved the direct intervention itself, which consisted of an educational 1 hour training program for clinicians and an EHR order form that helped normalize LAI prescribing at the time of the initial antipsychotic order. In the refreezing phase, effort was made to establish permanence for the changes, integrating resources such as rapid response guides, prompt text, and preloaded order forms in ways that enable continuation of new prescribing patterns after the educational components of the project had been completed. Lewin's theory was a particularly apt framework for the proposed project because it specifically identifies the role that resistance plays in hindering change, provides a process for moving forward towards stable and evidence-based change. This qualitative improvement project employed a quantitative retrospective chart review with pre and post intervention comparison design. This design was appropriate since outcome measures, including antipsychotic initiation, type, and readmissions, were available for review in the electronic health record. A protocol, which included a 1 hour didactic presentation for clinicians and nurses, was accompanied by an order-embedded LAI initiation protocol for LAIs prescribed by the clinicians, with documentation that the LAI prescription had been offered and accepted for each patient encounter. This approach afforded a direct before and after measure of the prescribing behavior with regard to LAI and the readmission event without system modification or participant data collection burden. A z-test for the difference between two independent proportions was employed since readmissions was a dichotomous categorical variable and since LAI initiation was a dichotomous categorical outcome. This method provided a direct answer to the study's research question whether organized instruction and ordering had been sufficient to modify clinical practice to increase prompt LAI initiation and decrease readmissions. The final analytical sample was composed of 2,892 adult patient records from a psychiatric crisis stabilization unit with 1,596 patients in the pre-intervention and 1,296 patients in the post-intervention cohort. Patients were all adults aged between 18 and 65 years and were selected on the basis of first episode of psychosis, first episode of schizophrenia, because this is the age range at which interventions for first episode of psychosis are expected to yield maximum clinical impact. We included both genders and a representative range of race and ethnic groups to approximate the clinical services patients population. Within the post-intervention cohort, 17 patients had a prescription for LAI antipsychotic as part of the treatment received during the time of the study. Given the retrospective nature and de-identified format of the EMR data, our demographic data was not comprehensive for both cohorts, and so we focused mainly on outcomes in terms of readmission and relevant intervention associated variables rather than detailing demography for the total sample. Data were analyzed using a z-test of the difference between two independent proportions for two dichotomous primary outcomes: the presence of at least one initiated LAI and psychiatric readmission at 30 days and 60 days post-discharge. The independent variable was clinician education plus standardized protocol. The dependent variables were 30-day and 60-day psychiatric readmissions. Descriptive statistics describe characteristics of the study samples. Inferential statistics evaluated pre versus post-intervention proportions, setting the significance criterion alpha at 0.05. Confidence intervals for proportions and post-hoc power for the statistical test of readmission rates were calculated. This test statistic was chosen as it directly evaluated a transition in dichotomous outcomes caused by an intervention, as is appropriate for a quality improvement project. 30-day psychiatric readmission rates reduced from 8.8% to 8.0% between the pre-intervention and post-intervention groups, and 60-day psychiatric readmissions reduced from 2.8% to 2.5% during the same period. None of these differences were statistically significant with an alpha of 0.05, and both of these 95% confidence intervals overlap zero, suggesting that these reductions may be the result of chance and not of intervention effects. It should be noted, however, that 94.1% of the 17 patients who were initiated on an LAI in the post-intervention period experienced no psychiatric readmissions at any point, an expressive trend that is clinically significant and consistent with prior published literature. Survey results from clinician and discharge planners also indicated an increase in awareness of the evidence supporting the use of LAIs, greater likelihood of ability to present the advantages of LAIs as a first-line therapy, and an enhanced awareness on topics of medication compliance and discharge planning. Table 1 summarizes the comparison of psychiatric readmission rates before and after implementation of the evidence-based intervention. The 30-day readmission rate decreased from 8.8% to 8.0%, while the 30-day readmission rate decreased from 2.8% to 2.5%. Although both outcomes demonstrated a favorable downward trend, neither reached statistical significance, as the p-value exceeded the predetermined alpha level of 0.05. Additionally, the 95% confidence interval included zero, indicated that the observed differences may have occurred by chance. Overall, these findings suggest a positive clinical trend following the intervention. However, the small sample size and low statistical power limited the ability to detect statistically significant differences. Several important limitations must be noted when interpreting this result. Because only 17 patients received LAIs in the post-intervention period, statistical power was low and the capacity to detect a group level difference that was clinically relevant, although the trend was favorable. 30-day and 60-day follow-ups are standard psychiatric quality indicators, but they cannot reflect longer-term relapses or readmission rates. Also, the study is retrospective and single-site, relies solely on de-identified fields of the EHR rather than clinical narrative note data, and can only provide information about a single hospital included in the analysis, so generalizability may be limited. Low statistical power for both 30-day and 60-day analysis also limit the project's ability to definitively conclude a small or moderate-sized group effect. Further research in a larger, longer, and multi-site trial is required. Results from this quality improvement project aligns with the current literature supporting long-acting injectable antipsychotics or LAIs. While statistically significant improvements was not met for either outcome, clinical improvement was seen for both 30-day and 60-day psychiatric readmissions. A small but important increase in the clinician's knowledge was observed through improved survey scores on awareness and confidence when addressing early use of LAIs. This successfully fulfilled this project's aim of changing the clinician's prescribing behavior. Lastly, the EHR embedded protocol did not interrupt clinical workflow and was successfully implemented into the patient's care. This demonstrates the acceptability of this practice change. As a whole, the project incorporated elements of Lewin's change theory. They show how clinicians can be prepared for change and implement an evidence-based intervention in order to progress towards practice adoption. Future studies with larger sample sizes may be able to recruit sufficient participants with adequate power statistical tests and further investigate the impact of early LAI implementation on patient care. This project has significant implications for psychiatric nursing and advanced practice nursing. The project will position advanced practice registered nurses to conduct collaborative decision-making dialogues about LAI versus oral antipsychotic treatment of psychosis directly in response to the clinician reservations and myths which have suppressed timely initiation of LAI use. Registered nurses will be instrumental in early recognition of relapse, facilitating medication adherence, and coordination of injection schedules across the continuum of care. In addition, the project illustrates the value of interprofessional teamwork of psychiatrists, nurses, care managers, nurse practitioners, and discharge planners in smooth, safe transition from inpatient to outpatient care. Given the intervention was designed to utilize existing EHR workflow and infrastructure, it will be of no cost with respect to staffing or technology, enhancing the sustainability and potential scalability for practice settings beyond our own. Lastly, this research further emphasizes the importance of providing equitable access to LAI treatment for all patients, regardless of insurance status and fragmentation of care. Overall, this quality improvement project demonstrated that clinician education combined with implementation of standardized EHR protocol is a feasible and practical strategy to promote the early use of long-acting injectable antipsychotics or LAIs within an acute psychiatric crisis stabilization unit. Although the project did not demonstrate statistically significant reductions in 30-day or 60-day psychiatric readmission rates, the clinical trends favored the intervention and were consistent with the growing body of evidence supporting the early use of LAIs to improve medication adherence and reduce relapse among individuals experiencing a first episode of psychosis or schizophrenia. Several factors likely influence the findings, including the relatively small number of patients who received an LAI during the implementation period and limited follow-up timeframe. Despite these limitations, the project demonstrated that implementing evidence-based practice changes within a busy clinical environment is both achievable and sustainable through interdisciplinary collaboration, clinician education, and standardized workflows. Completing this DNA project has strengthened my ability to translate evidence into clinical practice, evaluate outcomes using quality improvement methodology, and lead system level change that promotes safe, evidence based care. It has reinforced the importance of engaging stakeholders, overcoming implementation barriers, and using data to drive meaningful improvements in patient care. Moving forward, I hope to expand this quality improvement initiative to additional psychiatric settings and larger patient populations while incorporating longer follow-up periods to better evaluate patient outcomes. My goal is to encourage earlier adoption of long-acting injectable antipsychotics, improve treatment adherence and continuity of care, reduce preventable psychiatric readmissions, and ultimately improve long-term recovery for individuals experiencing schizophrenia. These are the primary references that guided the development of this quality improvement project. Thank you for your attention and the opportunity to present today. I welcome any questions or feedback.